Vermont Early Childhood. The Child Outcomes Accountability Team is one of the VCAP committees, the Vermont Early Childhood Action Plan Committee. So, this is the table where we try and bring people together cross-sector to talk about well-being of children and families, particularly the first goal, which is all children have a healthy start. So we are often talking about things related to social determinants of health, early, kind of prenatal care and early childhood development, those types of things. And with the goal of both seeing what are we doing well and kind of elevating those pieces so that we can try and continue to invest resources, as well as identifying gaps in the system that may turn into policy recommendations that the State Advisory Council issues annually. And so this particular group jumps around on topics quite a bit, somewhat intentionally, that we are trying to dig a little bit deeper into different areas of kind of well-being, right, for children and families, and what is needed. So in planning today's meeting, working with Katie and Margaret and identifying some of the challenges that we had been hearing around for certain populations struggling to access home visiting. Sabrina, we're going to mute you. There you go. So it's great to have you all here. I think because of who's in the room, we're going to please make an intro into the chat. I am joined by Jen. Do you want to make a quick intro as kind of my partner in crime in supporting the committee?
Sure. Hey, everyone. I'm Jen Schulmeyer. I'm the data manager here at BDF and joining the group committee supporting Beth. I'm looking forward to learning more about your work and diving in. Thanks, Beth.
Awesome. Great. And I haven't seen Katie come in, but Katie Leffel is our public co-chair. So that's Coat. I know there's some folks who are not regulars at this group, and we're glad that you could hop on. So our agenda is that I'm going to hand it to Margaret, who's going to give us a little bit of the landscape of nurse home visiting, who's served, what data she has to share. We have a few, we have 2 nurse home visiting supervisor health directors, home health directors, who are going to talk about their experience of kind of who's being served and where those gaps are and how other states, I think Margaret will also talk about kind of how other states are addressing some of those challenges. And then we'll have time for discussion around what those gaps are, what the needs may be for state level kind of policy or practice changes, and BBF kind of continues to compile kind of what those gaps are and decide where that information goes. And if nothing else, we are elevating that gap here at this kind of more public cross-sector meeting, which is super important. Any questions as we get going? Awesome. Margaret, I'm going to hand it to you.
Okay. I'm going to bring up my slides, make sure that that's all working. And is this in, oh, I'm in presenter view. I love that. Are you seeing this in presenter view?
We are, yes.
Okay. Hide presenter view. I did it. Oh my gosh.
Good job.
Woohoo! So good morning, everyone. My name is Margaret Urban. I'm with the Family and Child Health unit of the Vermont Department of Health. I'm the Strong Families Home Visiting Program Administrator, which is part of CIS, really overseeing the MESH program, but really supporting the continuum of home visiting within CIS Strong Families. And I wanted to have kind of our panel introduce themselves. Maria, do you want to go ahead?
Sure. Hi, all. I'm Maria White. I'm from Children Integrated Services. I work with Margaret and Karen from the Strong Families Vermont, and I am in charge of the responsive family support and responsive nursing. And it's nice to meet you all.
Stephanie, welcome.
Good morning. I'm Stephanie Moser. I'm the Director of Maternal Child Health at the Visiting Nurse and Hospice for Vermont and New Hampshire. We are the VNA agency in White River Junction, and we cover the most southern territory up to Orange County along the Connecticut River.
Thanks, Stephanie. Amy?
Hi, I'm Amy Wenger. I'm the clinical nurse manager for what is now the VNA of the Southwest region, serving Franklin County. And we serve Franklin, Grand Isle, and Lamoille counties for different programs.
Thanks, Amy. So yeah, we're excited to just have a little time with you all to talk about universal home visiting and a bit more about our current system of care, and really want to highlight some of the gaps and really give the mic over to Amy and Stephanie a bit more about kind of their day-to-day on the ground experiences. So we're going to start with just really talking about universal home visiting, what it is, what are the benefits. We are going to really take a look at our regional partners in New England and what sort of universal home visiting systems they may have. We will dig a little bit deeper into our home visiting system that we have in Vermont and talk about some gaps and just kind of summarize some barriers and have some time for discussion. So for starters, just want to kind of define what universal home visiting is. So when we say the term universal home visiting, we really mean that every family who has a baby is referred and has a nurse home visit, regardless of income, regardless of insurance coverage, regardless of risk, whatever complications they might have had at birth. Doesn't matter what their demographics are, their family size, because all families can benefit from a home visit after having a baby. Universal home visiting can literally bridge the gap between parents and the community resources, and we are so rich with resources in Vermont. The literature shows that universal home visiting models have a positive impact on health at a population level and can connect families with identified needs to community-based resources and support them, and can also do an amazing job of connecting families with home visiting services that are available, and decipher sort of the eligibility and nuance, because of course there are many. Ultimately, home visiting that's universal can help families avoid significant challenges like unaddressed maternal depression, and they can just be supportive, right? These are preventative services that can support parents' knowledge. They can build confidence for caring for their baby, and just bottom line, help families to flourish. Universal home visiting is really mimicking our healthcare systems of practice of universal well baby visits, right? So like in America, you have a baby, there's this AAP well child visit schedule, and everyone goes to the doctor for that, just had a baby follow-up visit, the 1 week, the 2 week, and so on and so forth. This is preventative care. We monitor growth and development. We talk about eating, we talk about care, we talk about questions, it's anticipatory. So universal home visiting is really mimicking our preventative care system that's part of our healthcare. And in other countries, home visiting is universal and it's part of their preventative system of care. All families can benefit from additional help. All families have questions. All families have some concerns at time, and the universal home visiting can really connect families to additional supports or services. Next, I just want to highlight a few key research papers and really kind of highlight some of their key findings. So all of these papers found that the universality of home visiting is key to reducing stigma and increasing receptivity to home visiting. Key. The universality is key. So first, we're going to just take a quick look at this peer-reviewed journal in 2019, this orange one, which was really exploring the efficacy of universal nurse home visiting. And, bottom line, they found that this universal approach helped people who weren't typically targeted to public health or social service programs get reached. I just want to point out that these services were described as an essential part of postpartum care, and that those who received care were more supported with their physical and mental health. This next study, the randomized in the middle here, this light green one, randomized controlled trial of Durham Connects, which is sort of like the pilot project of what is now Family Connects, which is the only evidence-based nurse universal home visiting model. This one found that families who participated had better outcomes and were cost-effective. More specifically, mothers reported fewer emergency care episodes and more community connections, more positive parenting behaviors, participation in higher quality out-of-home childcare, and lower rates of anxiety than those in the control group. So lastly, the dark green one on the right, this was a paper about lessons learned from the first 3 years of implementation of a universal nurse home visiting in Massachusetts. And they found that universal nurse home visiting can reduce stigma associated with need-based programming. Universal home visiting reaches more families and addresses more needs and ultimately reduces stigma. So those were some key findings that I just wanted to highlight. Next, we're going to take a look at our New England partners. So let's highlight Massachusetts first. Of all of our New England partners, they seem to have taken the lead and been doing this work for 10 years now. And interestingly, they are modeled after Durham Connects. And this is a universal approach with a nurse visiting all caregivers, and they also have a follow-up call after the home visit. This is not considered an evidence-based home visiting program because it at the time didn't exist, but it really seems like it was modeled after Durham Connects, which is now Family Connects, which is an evidence-based nurse home visiting program. So this is happening in 6 primary communities. So universally offered, and it is 100% funded by MICV, which is the Maternal Infant Early Childhood Home Visiting Federal Grant. And it looks like they're working on scaling up and trying for sustainability. Next, our partners in Connecticut, they have a universal home visiting program in 2 areas of the state. So they're really working with 2 hospitals. And if you live in specified towns after giving birth at these 2 hospitals, they have universal home visiting. So again, it's universal, no target population or eligibility. You just have to have birth at this hospital and live in these towns. And they're using Family Connects, which is this evidence-based nurse home visiting model. And they have talked here about how this system of care then links with community health workers for additional services or referrals, and or also to their existing home visiting programs for sustained or longer support. They have funding through ARPA and CDC, and they're working with Medicaid approval for sustainability. Moving along to our buddies up in Maine and New Hampshire. Maine has this universal home visiting program where initial enrollment is available for all families with a baby 3 months or younger. And some populations are then prioritized for continued services beyond. Their home visitors are not nurses or community health workers, but have kind of specified hiring criteria and training for onboarding. They are utilizing the parents as teachers model and are touchpoints trained. And they are using McV funding, state funds, and Families First Prevention Act. And then lastly, just looking at our friends across the river in New Hampshire, they are not offering universal home visiting. There's currently legislation in place, and their proposed legislation is for a one-time resource navigation home visit to all families with a newborn with a paraprofessional. And that would help link families to additional home visiting services or other community-based needs. So I thought it'd be helpful to kind of take a look around our region and kind of get the lay of the land. Next, we're gonna really focus in on our own amazing infrastructure and also hear about some of the challenges within it. So we're gonna talk about our home visiting system. We're gonna talk a little bit about the data we have around the numbers that we can serve. We will highlight a few of our perinatal health outcomes specifically within the Strong Families Vermont Nurse Home Visiting Model, or MESH, and some demographics that we have available about the reach within that program. And we'll talk a little bit about perinatal loss and some changes within responsive home visiting. And then we really want to highlight some of the gaps and really hear from the managers from home health agencies about their experiences in this space. So just at the very beginning here, this slide is really kind of breaking down that we sort of have this preventative home visiting services system. So these are preventative supportive services, providing a schedule of screenings, and care coordination, case management, developmental education, preventative services. And then we also have kind of in the other bucket, home health, medical, nursing referrals. So these are medically indicated for lactation or skilled nursing need, doctor ordered, not preventative, and just kind of outlining a difference here. So we're going to delve a little bit more into the preventative work, which is at what we're going to speak to right now is really the Children's Integrated Services Strong Families Vermont Home Visiting System. And thinking most of you have heard of this, but just kind of a recap, we have a variety of services statewide under Children's Integrated Services, Strong Families Vermont. Our responsive home visiting is evidence informed. This is with a nurse or a family support worker. And we also have sustained home visiting, which we'll talk about a little bit more as well. You'll see this kind of light green universal home visits cascading to responsive and into sustain when we really branded our home visiting continuum back in 2018. We put aspirational universal on there, really recognizing that gosh, universal home visiting is a doorway into our system of care. And we do not have universal home visiting. I just want to make that clear. As part of our system at this point, there are some communities that have some programming that is universal and can be a doorway into other services. So just to kind of get a little bit more specific, in the state of Vermont, statewide, we have responsive home visiting services. These are evidence formed. This is through the CIS bundle payment. And then currently we have 2 sustained or evidence-based home visiting programs. We have 2 models. So the Strong Families Vermont Nurse Home Visiting Program is statewide and is funded by McV. We have 7 home health agencies that are sub-recipients and are trained and providing statewide services. We have the capacity for reaching 405 families a year. And we've been working away to stand up Strong Families Vermont Family Support Home Visiting Program, which utilizes the parents as teachers model. We have Medicaid investment, startup dollars, and are transitioning to Medicaid case rate and the capacity for 160 families. So that's just kind of a snapshot of the lay of the land of our prevention services under CIS. I do want to delve a little deeper into the Nurse Sustained Home Visiting Program known as MESH. The MESH model is really our home visiting program that is to be universally offered to anyone who is eligible as part of our current system of care. This model works best when we can work with families prenatally. It has a fidelity measure of enrolling 80% or more of our families while pregnant. And the nurse home visiting schedule is really designed to support that perinatal period. They are visiting weekly after birth. And just wanted to kind of highlight some of the favorable results from studies regarding the impact or outcomes of this model. So it's shown to improve maternal health, child development and school readiness, and positive parenting practices. This is showing the reach of the Strong Families Vermont Nurse Home Visiting Program. We served 429 families in the last fiscal year and made around 3,000 home visits. And this is on the map here showing our home health partners that are doing this work and their affiliation with the CIS fiscal agent. So this slide is really just a quick hot wash of all the things going on, specifically in the sustained home visiting programs. Want to point out that visits are occurring at a place of choice, could be at a community-based setting, and with the sustained home visiting programs, this is for a duration of about 2 years. The nurses are beginning prenatally and ideally staying with the family until the child turns 2, with the frequency of the home visits decreasing over time. Nurses are able to do blood pressure checks. They are skilled in lactation. They are screening and coordinating care for perinatal mood and anxiety, all sorts of other things like substance use, intimate partner violence, and just doing a ton of care coordination, addressing social determinants of health. These are programs that have curriculum around parenting, social emotional, parent-child interaction, and general parenting skills. So moving along, this slide is just kind of showing that we have room to grow with our Strong Families Vermont Nurse Home Visiting Program, and really just wanted to move along here and show that some of the perinatal outcomes associated with this model. We are able to track 19 measures. These are kind of our subset of perinatal health measures. And so we're tracking preterm birth, we're tracking breastfeeding at 6 months, we're tracking those that are screened for depression within 3 months of enrollment, families who are receiving well child visits, families who are receiving that postpartum check after birth within the 8 weeks, and families who are smoking, what percent are referred for smoking cessation. So I'm going to move along and just wanted to kind of show you a little bit of demographic information about, this is just some of the demographic information that we have to share, but just to kind of give you a profile. The majority of our families are low income, and they have a good third of them have had a history of child abuse or neglect, or interaction with the child welfare system. And a good third of them almost have had a history of substance abuse or need substance abuse treatment. And I think those were the kind of the primary things I wanted to highlight on this slide. Just and lastly here that, we're tracking sort of the racial and ethnicity of families we are serving as well. And we are continuing to do more to try to reach diverse families, and really shore up our ability to have families enroll in this program and support their family needs as a way of reaching our health equity goals. I'm going to turn it on over to Maria.
Hey, trying to look. Oh, this is not the slide I had, but that's okay. We will push forward.
Yeah.
So I apologize. This slide was not the original slide I was thinking, but that's okay. Let's keep going. That's fine. So CIS responsive is an evidence-informed service to assess the immediate need and work with the family on the identified needs. This support can be done in responsive without timelines or curriculums. And as we've been saying, Strong Families Vermont is 0 through age 5, right? The needs can be, as we've stated earlier, resources, referrals to increase family stability, help boost confidence in parenting with ASQ assessments and support for development, and share what to expect as child grows. From tips to helping your baby sleep safely, to breastfeeding and nutrition support, to your care of self, to finding childcare, and preparing for school. So I wanted to touch on what we've changed a little bit. So we have made accommodations for the perinatal bereavement, which may occur due to miscarriage, stillbirth, planned termination, medical termination, or early infant death. Bereavement services include assistance in developing healthy and effective coping strategies, resources to help siblings of all ages cope with loss, connection to relevant support groups, and referrals and gradual transitions to other professionals who specialize in perinatal loss. One thing that we are working towards is I've recently become a trainer for the Intimate Partner Violence CUES, Connected Parents, Connected Kids trainings to educate the home visitors on these materials. It's an evidence, CUE stands for Confidently Universal Educational Supports. It's an evidence-based intervention for providers that they can use to talk with all patients about the elements of healthy and unhealthy relationships. Excuse me. The plan is to train as many Vermont home visitors as possible in the CUES cards to help address the intimate partner violence in Vermont. Another aspiration we're working towards for the responsive folks is working on training all CIS home visitors in ASQ 3 and ASQ SE, and working towards having CIS sites using these tools more consistently to be able to access the data from the online platforms that we partner with. And lastly, the CIS Strong Families Vermont Responsive Home Visiting, we are currently working on crosswalking and highlighting areas of alignment in CIS semi-annual report and CIS Strong Families Sustained Home Visiting, like the MESH model and the Parents as Teachers model data collection. And I hold a quarterly meeting open to all responsive providers and occasionally all of CIS providers, depending on the topic. These topics can range and are actually requested by the CIS Strong Families Vermont Responsive Home Visitors. And they can range from trainings on supporting families who are unhoused, affected by substance use, or where there are concerns of child abuse or neglect or mandatory, and on how to do and conduct mandated reporting. Could not get that word out. And that's all I have. And I guess I'll have to send the slide that I had. I apologize. I must not have saved it properly, Margaret.
I'm sorry. Yeah, we'll fit that in when we disseminate these. I'm sorry, Maria.
It's okay.
Thank you. So we wanted to kind of review our current system of care and then really turn it over to Stephanie and Amy to hear a bit more about what's this like and the gaps that they are facing in their services.
Yeah, thank you for including me. This is a really timely topic, as I've seen a change in the last 6 to 9 months. We have a higher level of patients that are being covered by commercial insurance. I would say previously the patients that we saw for medical visits, and not the preventative program, Strong Families or MESH, that Margaret was referencing, but our our medical visits were primarily Medicaid patients. And so we have seen this increase in those patients with commercial insurance for themselves and for their newborns. And at initial glance, as someone who's financially responsible for the programs that I oversee, I thought, wow, this is a great thing, because the reimbursement is higher. But then what I have started seeing is that actually we may have more people on private insurance. However, we're not able to cover services for them. We may not be able to even get to admitting them onto service because their insurance does not have any special carve out for postpartum patients, or for home visiting services. So what I am seeing is that postpartum patients must be homebound. Their infants also need to be considered homebound. Um, and then there is also the need for some insurance to say that visits are not authorized unless there is an injury or illness. So when we think of a situation where, excuse me, when we think of a situation where there's an uncomplicated birth and delivery, and mom might benefit from home visits for reinforcing care of a newborn, establishing feeding, and general support. This does not fall into what I am seeing that commercial insurances are requiring. So I wanted to share an example. As Margaret had stated earlier, the MESH program, the Strong Family Sustained Nurse Home Visiting programs, are at the home health agencies. So I have nurses who see patients for medical reasons, and I also have those nurses that provide the preventative model, the Strong Family Sustained Nurse Home Visiting program. So we are able to team together, and that is a really great benefit for our communities. We had a referral for a non-complicated postpartum mother and child, and the mother had inquired, was interested in having visits to support her in that postpartum period. And so this was a medical referral. It came into us from a doctor at the hospital. And we did accept the referral as a medical referral, but then when we looked at the insurance, realized that we would not be able to cover this patient on our service in this way. And so I had one of our Strong Families nurse home visitors reach out to the family to see if they would qualify for the Strong Families program. in many cases, we are able to find a way for families to meet that criteria. There is an income requirement for being in the program, and it's a fairly I would say it's a fairly easy requirement to meet in the state of Vermont. Um, Especially if a postpartum person is not going to be receiving income in that postpartum period. Um, so I would say that oftentimes, excuse me, oftentimes we're able to get them connected to the Strong Family Sustain program if they don't meet the criteria for medical. In this particular case, the patient that we had referred to us did not qualify for the Strong Family Sustain Nurse Home Visiting program. So this person was a business owner and was very successful, and was still looking for supports. Unfortunately, they did not meet the guidelines. So the guidelines for meeting the Sustained Nurse Home Visiting program are to be Medicaid eligible, or to be receiving WIC. And so, so if someone does not meet that income requirement while they are working, like I said, sometimes if they are not being paid in that postpartum period, it can qualify for them for the program. The and the income that is considered is only the birthing, only the woman, or not the partner. So it's not the household income. It is just the person who gave birth. Um, and so in this particular situation at our home health agency, we were not able to find a way that we could support them with our staff. What we did do was look to our CIS team. So the Strong Family Sustained Nurse Home Visiting Program is part of the Children's Integrated Services. We looked to the appropriate team, and we asked if they would be able to reach out to the family in order to provide them support. The responsive the responsive programs are able to, or the programs that are at CIS are able to provide services to people with commercial insurance, but there is a cap to that. It is 20%. And I know that in this community and in others, that the number of people receiving services with CIS who have commercial insurance is growing and is pushing the boundaries or over that 20%. And so this served as a point of conversation for us in this community, and again is really a great timing for it to come back to an even larger audience to say, this is what we're seeing, and how can we best serve these families. So in this case, we did go through a number of different avenues, and ultimately the family is being served by CIS, but like I said, there are some limitations with providing that service in certain areas. Thank you.
Thank you, Stephanie.
Hey there, Margaret. Oh, there it is. Thanks, Steph. What you just spoke about it truly is a barrier to providing services. And it definitely makes it more difficult, and it takes more time when a lot of the time some of our services are just in time services. But minding the gap is something that's always on my radar as a home visitor. I'm a lactation consultant, and I'm a maternal child clinical nurse leader, and I'm responsible for looking at these systems of care, from a bird's eye 360-degree view with my community partners so we can find better ways to serve our community. And I'll tell you that the gaps in maternal, child, and family health are pretty vast, and the issues are persistent and real. But the outcomes that we are continuing to put our focus and respond the most to are really where the system is failing or has failed. And honestly, sometimes I feel that those systems failed generations before we were born or our clients were even born. But I find that the gap is not really only about where our perinatal care system is failing or has failed. It's kind of more about where the system has become stuck, just kind of like Stephanie was talking about, stuck to the point where it's becoming obstinate, confusing, and oftentimes inflexible. And this is where, for us who work in this system and are trying to serve, become a little bit frustrated, because when it does become stuck like this, it affects every single pregnant, birthing, postpartum, and parenting person in the same way, and not just the ones who have the highest risk factors. This slide here shows kind of a picture of how our current culture feels to a perinatal person. In pregnancy, especially first pregnancies, the pregnant person is often supported outside of their home in community clinics or and in the hospitals by their obstetric providers. And there's a really big heavy focus on that on the birthing day. And pregnant people typically don't focus or prepare themselves after the birth of a baby. And I've taught childbirth ed classes, and we do a lot of talking about, that the day and what we can do to prepare for that day. And I find when I offer those newborn care classes, although those have gotten bigger, in the past few years, they're not as attended. Most pregnant and birthing people are, they're kind of, when they're pregnant, they're far away from the edge of the cliff, or they're even unaware that there is a cliff at the end of pregnancy. And as that focus goes from the pregnant belly to the baby, a transition that's obvious in our culture of baby showers that are filled with cute baby clothes and big diaper cakes, and well-intentioned families and friends that come to visit and just hold the baby after they're born. We're kind of missing the mark. Who's supporting the dyad? Who's supporting the mother, the partner, the family? And then once that baby's born and discharged from the hospital, they're literally pushed off a proverbial cliff and into the kind of postpartum abyss, where there's no structure or setup to support every person consistently to obtain the resources or help that they need. And unless you're set up prior to delivery, help does not come to you, and it is not always accessible. And if you don't qualify or have a clinical need, meaning a medical need for any home visiting programs, it can be very expensive and not a feasible option for many pregnant and birthing and parenting people in our state. Private doula services in Vermont cost an average of $1,500 to $2,300. And insurances like Blue Cross Blue Shield, Better Beginnings may subsidize a small portion of that, but sometimes for those who are on the benefit cliff, that can be really a big barrier. Through the Affordable Care Act, lactation support services and lactation equipment are supposed to be covered by most private insurance companies without any cost sharing, co-payments, or prior approval, but there are loopholes, and insurance plans that have been grandfathered to make accessing lactation support services difficult are sometimes too expensive because families have to pay that co-payment or pay down their deductible. And for those who are underinsured or may have immigrant health insurance plans, or they become a parent through adoption, gestational surrogacy, or they had a stillbirth, a loss, they might not qualify for any supports and services and are often left out of the conversation. And I see this a lot happening in real time. If you're not connected to support in your community in pregnancy, everything must be resourced by that exhausted, anxious person who is now trying to kind of navigate this system of care. And it's confusing, and it feels lonely and scary and isolating. And we live in a world where independence is glorified, vulnerability is seen as weakness, and rest is never promoted. Our new parents are they're suffering, and they're they're not even really aware that the support that they are not getting is lacking, and that that their health and wellness is not being seen as a priority, and that is what is really keeping our perinatal systems really stuck. Can I have the next slide, please? We know that in pregnancy, birth, and the first postpartum years, like this opportunity, this touch point lays the foundation for long-term health and well-being for both the women, for both the birthing person and her infant. And we need to bridge this gap for all families out, and it has to happen outside of a clinic or a hospital. It needs to happen in that person's community and in their home, where they can get the support that they deserve right there with community supports that are easy to access. And we need to do this because it will move them further away from the edge of that cliff. It will give them a resource or resources to be able to not have to feel like they're so alone and have to find these things on their own. Because the system itself can be really difficult. This must be universal. It must be continuous, and we need a continuous infrastructure that literally becomes woven into our culture so that the help is accepted before it becomes crisis. Because, if you've ever had a child or someone that does, you just know how close that proverbial cliff is at all times. I mean, I have teenagers, and many days I still feel like I'm postpartum and all alone and just trying to find my way through as I'm navigating being a parent. But as a nurse home visitor or home visiting systems in general, we are able to meet people literally where they're at. We can honor and respond to person's needs. And, when we enter into a client's home in a very preventative way, we can respond to any issues that are going on. And, we know that we can't do it alone. We've got these rich resources in our communities that can be accessed, but we need to sometimes really think about we have to think about all of the things, like what kind of insurance do they have? What programs do they qualify for? What are we able to give them when they really just need everything? And this is across the board. We're able to, we are specifically trained as home visitors, and I mean that across the CIS spectrum, to support this population. This is a population that kind of gets forgotten in the grand scheme of things. And we have wonderful programs to do so, and appropriate supports that hold this space in really powerful, powerful ways. And the impacts last in so many ways. And when time and time again, I have a client who, that I'm seeing for lactation that is she's privately insured, and she, that baby is actually feeding just fine, but she keeps coming up with things that are going wrong. And, it was me just sitting down with her and her kind of telling me that she and her husband are really struggling, and that, they need support. And, where I can't stay in there because I'm in there through her insurance for in a medical way, under medical orders for lactation consultation, it's not appropriate for me to stay in there in a preventative and sustained manner. Luckily, in my community, I have resources that I can get in there ASAP, but that's not across the board, and it's not universal for everybody. And that impact of me being able to be there, ask those questions, and be able to refer out and get them the supports that are going to help them longer term is it is huge. That that mom still emails me, we still and we still chat, and she asks questions, and it's a resource. I become somebody that she can ask those questions of in a really appropriate way. And she's told me how much she's impacted our life. She's told me how much the community doula that we brought into the home has impacted her life. And I need everybody to kind of think about that for a second, because that impact is really the essence of why we do what we do. And so I want you to all just think for a second about a vulnerable or transitional time in your life, when somebody showed up for you and made you feel supported and saw the potential in you and gave you those helpful resources, and how that may have changed your perspective and pathway forward. When you were supported in a way that you could ask for help and you felt safe to do so, or you were safe to fail, where your successes are seen, celebrated, and you're given the opportunity how to make those changes and become a better you and build that resilience so that you can say in the long term, I did that. I got myself help. And that opens you up to accepting help later on in your world. And that is powerful in itself. And so that's really why we need to kind of move home visiting from just focusing on those the places where we know need focus, and also expand it out, because everybody during this specific period of time in their life cycle deserves all the help that they can get. Thank you.
Thank you so much, Amy. Just this last slide is really summarizing a lot of what we've just gone over. That there are eligibility requirements for some of the programs some of the prevention programs we do have. We heard a lot about private insurance being limiting, and that there isn't a standard coverage for prevention. We've certainly had some questions with referral sources or providers being concerned with eligibility and not wanting to sort of promote and refer and not be sure and know that they will get something and what that something is. So that's sort of a case for if it was universally available, maybe there would be more confidence in sort of referring for services. We've had some challenges with systems being siloed. And just lastly, I think ultimately stigma attached to accepting need-based programs plays a huge part in receptivity. And if we just sort of had a different approach of, you're having a baby, there are going to be questions. We have a home visitor for you to support your questions, because you're going to have them, and this is part of your postpartum care. It's not because you need it, it's because everyone has questions, and we have these services to support this process. So we've got some references and just a discussion slide, and we will certainly update this before we send it out. I'm going to stop sharing so I can see more.
Thank you. What an incredible amount of information and perspective on on home visiting in Vermont and really across New England. We had some questions in the chat, and I wonder if we want to do some of that follow-up and then be able to move into kind of what next, like what needs to change to be able to do a better job of building that bridge. I love that slide that you shared, Amy. So some of the questions that came up in the chat, one was, is the population of folks who are covered by commercial insurance that's growing inclusive of underrepresented groups receiving services? I think that came from Renee. I don't know if you want to share what you were thinking.
Yeah, hearing you read it out loud is like, oh God, what was I? That wasn't what I just, as we're talking about gaps and trying to identify the neediest of the needy, like, because I'm thinking very much about the landscape, right? And how we're not blending maybe, but layering funding and how we're triaging. And I hear and understand that like it's getting universal, yes, like I'm with you, Margaret, like as someone who is currently carrying, like that would be great to have someone be like, this is just what happens and here this is. And yet we do have limited resources. So on one hand, I hear us talking like even the demographics, like how are folks of color being reached in this, and how are English language learners being reached? But then on the other hand, we're hearing that like, well, commercial insurance is growing and it's not covered. So I'm just trying to hold those two things and figure out, are the really vulnerable folks the ones who are growing with the commercial insurance, or is that kind of a separate need, and there's still really a need to focus on reaching the folks not on commercial insurance who are the most vulnerable?
Can I ask what you define vulnerable?
Yeah, so I'm thinking about children with potential medical challenges. I'm thinking about families experiencing homelessness, English language learners, families with a parent who might be incarcerated, those kinds of populations.
I can speak a little bit to that. I have not run the data on this, so this is only really my experience in what I've reviewed, and there does seem to be gaps. So we are discharging someone from our services, from medical services, I would say. It's a new baby that had a traumatic birth and potential brain injury. Their insurance is not going to cover it because they are not homebound. And so that is just one experience in addition to what I've already shared. So yes, I'm finding that there are fragile infants whose parents are not receiving the support,
The same, yeah.
potentially.
The same here. TRICARE is one of those insurances that is very difficult. You must be homebound. And that is because their rules are more for the Medicare population, but because it's Medicaid, Medicare, it all kind of trickles down into one. And I sat on, I was talking to a billing department and I said, well, they literally can't reach the pedals of the car and they can't even hold their neck up. They're literally homebound, but they're not considered homebound because they, as a newborn infant who's, might have medical complications. And that could be anything from slow weight gain and, needing lactation support. Lactation support has to go under the person with the equipment. So the person who is lactating. And so if something comes through, under, where a baby's gaining weight, I have to admit the mother or the parent, the lactator, to my service. And it depends what insurance that person has. And the baby isn't always, out of the baby is, I'm not putting it under the baby as the identified client. So it gets dicey. We try to make it work the best we can. And honestly, sometimes I will just say to the pediatrician office who calls me and says, can you please help? I'm the only lactation consultant in my county. I'll walk over to the pediatrician's office and do the right thing because that person needs to be served. And it makes it very difficult because at the end of the day, when we're talking dollars and cents, my agency, we need reimbursement in some sort of way, but we also need to service, there's a whole group that can't be serviced, but is being underserved. And it makes them vulnerable.
Can I just add on to that? I think what I would also say about the population that we serve at home health agencies is that our teams are often really small because this is not a mandated program under home visiting. Adult home health and hospice are programs that are supported by regulation. And so in many ways, this is sort of an optional program, and they're not always grown to their potential. And the reimbursement is low for home visits. I always just exclaim to people that this is the most important population that we have when we are visiting and educating someone who is pregnant or postpartum. We are not only influencing their health, but we are influencing a whole family's health and well-being. And so it's so ironic that we are the lowest reimbursed. And so I would say that there's potential to lose nursing staff given the fact that this is not generally a program that is a moneymaker for home health agencies. And so, so I think we're constantly in jeopardy of being diminished within our within our settings. And so I just want to bring that up for awareness as well, because that would be a real loss to the people in our communities and this population.
That's an excellent point, Stephanie. It's a two-generation approach, and I guess I think about the parallel in healthcare of primary care providers, and like you get the big bucks if you go into specialty practice and you're a surgeon. It's very paralleled.
And if you look at the outcomes being, like we see, it's like we know that this matters. We know that this sets people up, and we know that our perinatal population is struggling with so much more than even like it's never just, I'm never just in there for lactation. I'm in there for that, I'm checking their health, I'm checking their mental health, I'm screening them for all the things. I'm a head to toe assessment. It's never just, it's body, mind, soul. It's a conversation. And that's what, we're trained to do. And so I think, the visits are long. They're not, it's not a task driven, it's not task driven work, meaning that I'm not in there for wound care. I mean, sometimes I'm in there for wound care, but that's a different story. But I'm not, that's not the constant. That we're talking about the bigger picture.
I wonder if there's folks, it's been great to hear and that you came so prepared both to articulate the stories as well as kind of identify the gaps that you're seeing. I wonder if there are others who also have experience with home visiting who want to add, other additional gaps that you want to call out. Rena?
Yeah, Beth, thanks for that. Hi, everyone. It's Brina. There's so much to say in this space. I think I love the way Beth framed us at the beginning, that sometimes this group shares information and then actually wonders together about policy. There's a lot of policy stuff bubbling up with Amy and Stephanie, which I really appreciate. There's a long, long history here of growing and shrinking of the MCH nursing workforce in this great state. And it's such a sad story. And it all has to do with, you sort of make the case that maybe the medical homes are handling it. So then they shrink the MCH part of a home health. And then we say, no, that's different. It has to be a partnership and a team. And we love sending nurses into the pregnant people's homes, postpartum people's homes. So then they grow it back up. We get some federal funding, it grows, but not quite enough to actually make it a full-time nurse. The whole thing is fraught. So, and I think people know this, and if it's not true anymore, you can correct me. I think home health agencies have to pay a provider tax as though they're a hospital system. They pay like 19% to the sort of state system, which creates their overhead is just really complicated compared to other community serving children organizations. So I would love for this group to grapple with this. At the same time, what's bubbling up for me is how we need much more partnership between this nursing workforce and making the case to the medical providers. Like Margaret's already, and her team have really been working on this in the obstetrical space, but we need to push on it in the pediatric space as well. Because what you guys are articulating today is really important. I think the group here is right with you. I think there's a group of people who don't know everything that you're articulating. And then the last thing I'll say, because Margaret led with Universal, is a very interesting, so we're never going to be the land of plenty here where we can fund everything. So in my long career, we've made a decision that universal home visiting isn't the top priority because we have such good pediatric healthcare access for that first week of life. And in states like North Carolina, where Durham/Family Connects was designed, where my best friend from college is the health commissioner, they implemented that because they couldn't get people into the pediatrician. It was just so they didn't have good Medicaid coverage. They didn't have pediatricians taking Medicaid. So we do have a little bit of stuff to work out there. If there's money, great. But if we're picking an investment, it sits a little funny with pediatricians, the stories they tell is like Tuesday at 1 o'clock, the patient was late for their well check because the nurse came in at 11 because they were already going to see the babe on day 3. So I'm curious if we just want to call out a little bit of decision making in that space. And I'd love to know the New England examples are great, Margaret, because I can rethink it, but we just don't want to put a vast amount of resources into something when we're so starved elsewhere. That's the bummer about having to make decisions, including like Dulce, which is also something we're trying to grow. So if you're going to the medical home and you're getting that level of support, but you also have an amazing nurse home visitor, that's a lot of resource. And it's not my style at all to say we don't need all of it, but thanks for letting me talk.
Thanks, Brina. Are there reflections from folks on other gaps? And thanks, Stephanie, for the comment that thankfully the provider tax was eliminated. That's great to hear. Any other reflections? Yeah, Anne, go ahead.
I know, Beth, you just invited reflections on other gaps, but, and I know people realize this. I just want to express that there are gaps, and I love Margaret's, continuum slide, because we are building a continuum. We have both sustained and responsive new resources have come into both those sets of services recently. And in addition to the experiences of patients or clients or families, or however we want to say, who we're not reaching or providing, we're also providing some really terrific supports. And there are people that are being caught and held, and pregnant people who prepare well for the newborn days and have a community of support. So I just want to, celebrate the things that we are doing as we recognize that there are gaps to fill.
Thanks, Anne. Any other reflections? Perhaps not on gaps, but how does this relate to your work? We have a team from ESD here today, which I think is great. It's Renee, I appreciate you speaking kind of from the Head Start perspective. Others connections to kind of, if you've seen these gaps or your connection to home visiting. And then we can move into action and policy change.
I mean, I just offer it's probably important in this context for the group to know that even the array of home visiting services in Vermont provided by Head Start and early Head Start programs is changing dramatically as our workforce needs grow, and many Vermont programs are submitting changes in scope. We do have programs who have historically offered a home visiting model that are no longer doing that. So hate to be the one who comes on to be like, oh, actually it could be getting less than, but I feel like in the past we've had more capacity from that federal for those federal Head Start dollars to promote home visiting, and just currently that is shrinking in Vermont. So we'll put that out there.
So I don't know if this is the, Renee, we actually are meeting and want to hear more about all of the changes in Head Start services, and how that impacts larger systems. I don't know if this is quite the right place, but I just want to share my experience. I was had a medical need after the birth of my child almost 3 years ago, and received responsive home visiting, which was great. Very, very temporary. And then I really felt that gap in that slide. Oh my God, I'm gonna tear up. We went from like up to weekly visits with this, with my, midwife, who I developed this really strong relationship with. And then there was like a couple visits with a great responsive home visitor. And then there was nothing, right? There was like, we have a new parents group that meets once a week. And it was during COVID, right? So it was like, we're meeting outside and we're still like social distancing, all of the things. But the like that connection, and that's like, I do think of myself as having a strong support system, and I was well prepared, and I was supported by work and being able to take time off, but like the isolation was really significant, and not being able to have access to services or have somebody to say like, this is totally normal, or like, maybe we need to look at this. So again, just like sharing my personal experience. I think things have changed over the last couple of years, and obviously like the COVID pregnancies and early postpartum period is different now, but just again wanting to like share that gap is very real, even for those of us who were well prepared.
Thank you for sharing. Yeah, the gap is real. So what are the policy levers? I think there was, Margaret, you shared a great slide kind of summarizing some of those gaps. If we had our magic wand, what needs to change in your ideal world?
Would you like me to bring up the slide? I'm thinking that's a group question.
Yeah,
I'm not the
I'm putting it out,
spokesperson.
and
Yeah.
we're not going to come up with perfect language now, but just
Yeah.
this is an incredible group, cross-sector group of folks really thinking about and reflecting on those gaps. And so I can just read out some of what you had summarized. Talked about current eligibility requirements, private insurance with no standardized coverage, referral sources get this is small. Hang on, I'm trying to see it. Resources get concerned with eligibility and don't refer. Referral systems siloed and don't communicate. Stigma attached to accepting needs-based programs. So in terms of those are summarized, like what if like the State Advisory Council were to develop some policy recommendations to address even just one of those gaps, what are the levers that might be kind of pushed to be able to increase eligibility and address some of these gaps?
Well, this would be a great time for BBF to get involved with healthcare, because this is about MCH nursing. I mean, a big chunk of this is going back to the world we want to live in, which is that home health agencies have a commitment to the preventive MCH nursing that Amy and Stephanie do. And in that space is a recognition that in a health system, yeah, maybe it's you don't get the financial bang for the buck, but you make that up in the budget. Like, like the joke about pediatric offices is they should pair up with ear, nose, and throat across the street because we send all the kids for ear tubes. So healthcare has a way of neutralizing that. You don't make money as a pediatrician for the system, but the ear, nose, and throat does. So within home health, there's a nice reimbursement for, I'm not going to call any group out because I do that sometimes and get in trouble, but there are parts of home health nursing that are well reimbursed. So let the MCH nursing team be the preventive side. But what's right below the surface here, and I'll just call it out because I'm looking around, I guess, Anne, and for some of my longstanding colleagues, we got a little off track as an early childhood system in this space because we inadvertently pit family support home visiting with nursing. And it became kind of a, why would you pay for that because we can do the same thing over here and it's cheaper. I think that's really fading with some really, really great leadership, including Margaret saying, like, working so hard on the communication strategy of Strong Families Vermont, that it's a continuum that Reba Murphy used to say to me, can we all agree that pregnant people and postpartum people need nurses? Like, let's just stop fighting about that. And once we got there, and I guess Amy and Stephanie were probably around, we can stop with this sense that if we go into the public policy space for MCH nursing, we're somehow taking it from CIS or from parent-child centers or from childcare providers. It's like a zero-sum mentality that is quite, so just for this particular day, that's what I think we need. Doesn't mean we don't need money for Dulce and for parent-child centers and for CIS, which is why this whole thing's a big bummer.
Thanks for that, Brina.
Yeah, I mean, I'm just going to be bold and say that from my lens, I think everyone who has a baby should have a nurse home visit, period. It shouldn't matter what your situation is. I mean, clearly it's not a covered service if you have private insurance in most cases, unless you're reaching homebound status, which is hard to achieve. And we don't want that. We want a preventative system to get families connected to our system of care and reduce stigma associated with being like, are you sure that's for me? Maybe I'm not like, or what does that mean if you're referring me? We want to get over that mindset and shift it.
Well, and I think, oh, go ahead, Stephanie.
Sorry, thanks. I almost wonder, so hearing from Brina that that universal is not perhaps an option here, and I do agree with Margaret. I'm going to say every person
Well,
should
no,
have
Stephanie, I want to make sure. I love universal nurse home visits.
Okay.
But if you gave me $100,000
Yeah, I know.
and said you can either send a nurse out once on Tuesday,
Yeah.
or you can put a family specialist into an office to meet 160 babies next week. Do you see what I'm saying? It's a
sorry.
sad place. I love universal nurse home visits. Love them. I wish we
Yeah.
were Europe and all the great stuff Margaret just said. I'm talking about a finite pie.
Yeah, no, I recognize that. Sorry if I misspoke. So I recognize that. So I think when I think of what could we do next, my thought would be perhaps the next best approach, which would be talking about those options of either medical home visits or preventative programs at every pediatrician and OB appointment. So just making sure that families are aware that these services are available to them.
I'm just going to chime in with Stephanie and say that, I really think that was part of our charge with our marketing campaign is to really just universally promote. We have a robust system of care, and I'd like to refer you and really have done a ton of work at the local level to have our across the board service providers be aware and link people to the most appropriate services available that they can get them connected to, of course, a family choice. So I think consistent communication about it and referral from a provider perspective would be amazing.
And you just put something in the comments. Do you want to explain?
Oh, I'm just thinking about your question, Beth, about policy levers and, just things that we might put more emphasis on or try or whatever. And I think that the Dora's experience and some of what Amy shared, and I'm sure other people have addressed it, about social connection. And of course, things have changed since the pandemic, improved in some ways, but just changed, right? Life is different now. And so we know Strong Families Vermont, sorry, Strengthening Families, get my term right, emphasizes social connection as a protective factor. Yet very rarely is that reported. And how do we measure that? How do we attend to it in home visiting? How do we report it? And do stakeholders, ask to hear what are your outcomes in terms of social connection for the families that you serve, or and the people that you serve? I think Stephanie did a good job talking about the 80% Medicaid funding, 20% general funding in CIS. Of course, in my position, I can't, there are limitations to what I can say, but reviewing that and looking at what are possibilities around that might be an avenue. How that plays out in regions varies, because you can use 100% of your CIS funding can be Medicaid, and depending on the population in your region, you might not have much for general fund. So that's in the weeds, but and then, I think there was a lot about insurance companies and their coverage, and things that don't seem very logical. And so what is that another policy lever? Thank you, Beth.
And I have to say, that is an area I know very little about around like how do you impress upon commercial insurance that they should cover something different?
Yeah, well, I can speak to, this is reminding me of, so AAP, American Academy of Pediatric chapters have pediatric councils where you invite the Medicaid and the commercial insurers to come together to talk about things like that. And we just have taken a break on ours because there's so much health reform going on, and it was kind of a confusing meeting because people would come and say you need to have a code to pay for like standing by at a C-section. But that's where, and we're very lucky in Vermont that usually when Medicaid makes a decision to cover something, the commercial insurers follow. Like truly in child health, we've been able to say this is best practice now. It gets a little harder in this sort of bridging into community efforts, but there is a table to do that. We don't have that many insurers, so we do have an opportunity. It's not hard, but you have to have the right people. But usually Medicaid can help us.
Thank you. So I know all of this is very complicated, and certainly not asking for us to come up with any specific answers, but I see this as somewhat of a brainstorm, and then asking for those of you who are in this space to really think about what's our most feasible option if we are going to want to push just a little bit harder for change in the next year. So we're talking about relatively short term. What do we feel like those windows of opportunity are, and what's the lever? So would love, and I think we've brainstormed a whole number of potential options, right? Both thinking about Medicaid, commercial insurance, some state policies about what is covered and what is not, as well as kind of the work that we are already doing, which is trying to build a more integrated system so that people know what services are available to them, and trying to reduce the stigma, like those types of things, which is a little bit more in our realm of each of us showing up within our respective worlds to be able to make those connections. So we are coming up to our time. I want to thank you all for your perspective. I don't necessarily see this conversation as finished, but it may be something that we bring together a smaller group of folks to think about what those levers are. Would welcome your reflections in terms of what are those opportunities, where might we push in the next year? You know, in terms of building bright futures, we are just kind of one of those tools to be able to elevate some of these gaps, and this meeting was recorded intentionally so that we can kind of help share and spread that message. I think the specific stories that were shared are particularly compelling. So thank you. You know, this group comes together every other month. So and we are stronger when we are more representative. So would love, you know, the home health folks who joined specifically for this conversation are certainly welcome back. Jen, would love your comment as our outgoing thought.
Hi, I know we're coming right to the end, so I will keep it short. I really appreciated that whole presentation and this conversation a lot, and would love to talk more about it. Kind of a few things that stuck out to me as a parent and somebody who did receive home care from a midwife was kind of a paraprofessional and kind of peer-to-peer approach. I know nurses have a lot on their plates, and just everything with insurance. I could talk a lot about this topic, but those two really kind of stuck out for me as a parent, as something that could be more accessible, short term, and more immediate. So because we're at time, I'm going to stop there, but I would love to chat more with many of you about this topic.
Thank you, Jen. It's great to have you. Okay. Thank you to especially to Stephanie and to Amy and Margaret for putting this presentation together, and Maria. Really great to hear from you. I hope you guys have a good morning.
Thanks so much.